Is that Star Wars?
Yeah. Okay. All right. Okay, this is the hardest thing I'm going to teach you, and I want you to stop me, slow me down if I go too fast or nobody understands. Okay? And I'll warn you right now. There are many doctors who do not know how to do this. Okay? They are. Is everybody done with that?
Yeah.
So I don't want to lose that. It's like my Bible right about now. It's got so much junk in it from all the years. Thank you. All right. All right. There are many doctors that do not know how to do this. They either rely on the software that's in Epic, and we're going to talk about how that could be artificially inflated, or they just, I don't even know, they close their eyes and they point at the book. I don't even know how they choose their level, because some of them, the questions they ask me, I know that they are clueless, okay? And my daughter, when she was on rotation, she had her sheet with her, and some of the doctors, they've been in practice for 40 years. They don't know how to do this. So you know they're losing money, okay? Because you're going to get paid on an evaluation and management level on every visit. And there's 5 levels, so you've got to choose a level, all right? And so if you know how to do this and you go into a practice, then you're valuable. You can show the provider. And in fact, some of the PA students that I've taught, they tell me that this is now up on the wall in doctors' offices. They make copies. Okay. All right. Okay. New versus established. A patient is considered to be a new patient if they have not been seen by the practice within the last 3 years. That doesn't mean seen by you, that means seen by anybody in the practice. They could have seen your colleague, that's fine, okay, within 3 years. All emergency department visits are considered new patients even if they were frequent flyers. They're still new, right? But we're talking office visits here, okay? And basically, on your yellow sheet, new patients here, established patients here, initial hospital visits here, subsequent hospital visit is there, okay? And these are yours to keep, and it'll tell you what you need for each level. All right. Okay, so here's in the CPT book, here's your evaluation and management levels. Okay, office and or other outpatient service, new. Okay, and it says it requires 3 key components. Do you see that? Each of these new ones, it requires all 3 key components. All 3. All 3. And it's a problem-focused history, a problem-focused exam, and a straightforward medical decision making. You need all 3 of them to get a 99201. If you have a detailed history, a detailed exam, and medical decision making of low complexity, you have a 99203. Now, because you need all 3 of 3, let me give you an example. Let's say you have a detailed history, a detailed exam, and straightforward medical decision making. What level do you have now? A detailed history, a detailed exam, which is here, and straightforward medical decision making. I don't have low, I have straightforward. You have to back down to 202. Because you need all 3 to match for a new patient. Do you understand that? You need 3 of 3. Okay? Let me give you another example. Let's say you have a comprehensive history, a comprehensive exam, and straightforward medical decision making. What do you have? 99, 202. You still got to back all the way down. You need all 3 of these things to match up for a new patient. Because remember, it says you require these 3 key components. If you have all 3 in one level, that's fine. That's the level you've got. If you have 2 in one level and 1 in another level, you have to go with whatever the lowest level is, whatever that was, which I said, comprehensive history, comprehensive exam, straightforward medical decision making. I do not have moderate medical decision making. Now remember, this is all built on a hierarchy. Straightforward, low, moderate, high. This is a hierarchy here, okay? Obviously, the 99205 gets paid more than a 99202, okay? It's a comprehensive history. It's a comprehensive exam. It's high medical decision making. So you get paid more for that. So for a new patient, you haven't seen them in 3 years, or no one in your office has seen them for 3 years, and you need all three of them, all three key components. All right? Next one, an established patient. It's different. There's an established patient, 99211, 12, 13, 14, 15, and they need 2 of 3 key components. 2 of 3. So you only need 2 of 3, but one of them better be medical decision making. In fact, that's what CMS says. Remember, medical necessity is the overarching criteria. Remember the thing I pointed out earlier. Okay, anybody can inflate the history, because all that is check boxes. Anybody can do a full exam on you and say, oh, I got a comprehensive history, I got a comprehensive exam, I have a 99215. And they came in for an earache. Does that really justify 99215 just because you did a comprehensive history and a comprehensive exam and checked all those check boxes? Because remember, medical necessity is the overarching criteria, according to CMS. So that's why, basically, I work from the medical necessity and work back. What should the medical necessity for this visit be? Which is the other side of your card. That's your other side of your card. I use that side of the card and work back. I find out whatever the medical decision-making part is, MDM, medical decision-making. Is it low? Is it moderate? Is it high? And then I realize, okay, this is a new patient. I'm going to need 3 of 3. What do I have on the physical exam and history section? And then does that match? Or if it's a new if it's an established patient, I just need one of them. I just go grab the exam or the history. But I make one of them always the medical decision making. That way, I sleep better at night because I realize that the medical decision making is driving this code, which is what it should. The medical decision making should be driving it all. Okay, that's why several of you, scribes in the ER or whatever, oh, we clicked everything and made it a 5. Or they told us to make it a 5, or I saw them make it a 5. Yeah, you can document out the years. All their history and, all the HPI and their past medical and whether they smoke or not and what their family history's like. That's good. You get a full history for that. That's great. And then you can touch every part of their body and do a head to toe full exam, and it came in, for dental pain. Did you need to touch everything for a dental pain visit? No. Okay? So that's why a lot of this EPIC stuff and a lot of these electronic records are counting, listen to me, they're counting volume of documentation, but not appropriateness of documentation. You understand? That's why I work from the medical decision-making side too. I work from there and work back. And then I know that this visit feels like a 3, it feels like a level 4, it feels like a level 5. That's what it should be. And I'm not doing it the other way, which is what a lot of the electronic records are doing. They're counting history and exam. They're not taking into account the medical decision making. A lot of the electronic records, you have to put some sort of intelligence into it. How is it calculating this code? Is it looking at medical decision making as an overarching criteria, or is it counting just 2 of 3 somewhere? And it could be the history and the exam. And you could be artificially inflating your levels, and really you're getting paid more than you should. Okay? All right. 3 key components. Remember the 3 key components, they were on the first page. Here they are. History, exam, medical decision making. You understand? Here it is. The history is the HPI, the ROS, and the past family social. The exam, medical decision making. The box A, B, and C achieve 2 in a column. And the medical decision making is this. It's box A, B, and C. We're going to be coding 3 notes together. We're going to be putting all of this into practice and looking at real live notes and looking at the audit sheets, and we're going to code them together. Okay, so glazed over looks, I want hands going up. Please stop me. Okay, because like I said, this is hard stuff. Okay, but you guys, I've never had a PA class not totally get it or anything, so you guys are pretty smart. So like I said, all right, but I might go too fast, so you got to slow me down. All right. History is the HPI, the ROS, and the past family. History of present illness, review of systems, past family social history. That's your history. Okay? And this is a copy of what we have, okay? And this is your new patient. You see how I put up here? 3 of 3, you need 3 of 3 elements. And for an established patient, this is them. You need 2 of 3 elements. See, I tried to put all that junk on there for you. And then if you're like working in a hospital and you're working for like an internal med doctor and you're seeing a consult or whatever, the patient comes in and they're in the hospital, well, there's only 3 levels here. And they're there. You need 3 of 3, and then for subsequent, you need 2 of 3. And by the way, I know there's a typo on this page, and it's right here. You see this? And I've changed it on your thing. This should be a 99221, and on your thing it is a 221. I had to like go in there and write it myself, but I couldn't fix it on the slide right now. Okay, so I know about the typo. So there it is. Okay, so and then here's my name, here's my number, and here's my website. Okay, because when you get into the field, if you've got questions, if your doctor has questions, this is who you call. You call me, all right? All right, and here's the other side of the box, okay? The other side of your thing. And here's box A. What you do is you put everything in box A and you get a total. Do you see this? And then you take the results and you put them here, box A. And then here's box B. This is the table of risk. And you find whatever's going on, and you find you got high risk, moderate risk, low risk, minimal risk. Everything is cross. Cross. Do you understand? And then you come over here and you put that risk in here. And then box C is up here. And then you put that over here, and then you come up. You need 2 of 3 in that column for your risk. Basically, get this, and you can understand E&M leveling, because you all know how to do an exam head to toe. You all know how to do the other stuff. This is the part that really throws people. Understand this, and then your notes will be leveled appropriately. Okay, let me give you an example. On the APC website, and I'll give you the website for that later, I'm certified through 2 different coding groups, and the one has an E&M leveling benchmark tool. Okay, and what's loaded in there is 2010 data. I wish they had newer data. But it's CMS 2010 data based on the specialty that they coded. Okay, so basically what you do is you get on their tool and you put cardiology or dermatology or OBGYN. Okay, and then you push calculate, and it'll give you like a bar graph or percentages, and it'll tell you all cardiologists across the country, this is what their bell curve should look like. 1992, 12s, 13s, 14s, 15s. Okay? And so, here, sugar. Okay, you guys are gonna like really see it. Okay, so here we got level, I'm gonna say level 1, level 2, level 3, level 4. Do you understand what I mean by that? Level 5, okay? So level 3, level 4, level 5, okay? Now, a dermatology practice. Are they seeing heart attack patients? No. They probably have a lot of level 3s, don't you think? Okay, so their bell curve probably looks like this. They have very few 5s, they have very few 1s, they have a lot of level 3s, okay? Okay, but yet, a cardiology practice, their bell curve looks like this. A lot of 4s and 5s, especially new patients. They're coming in, they're being consulted for some reason in the inpatient world. They're coming in and they're being admitted. Okay, so I was involved in an audit for it was the one that the Medicare people came in. And I was working for a compliance department that had to keep them, I was retroactively continuing to audit them to make sure that they were where they should be. And I had, this is no lie, this was an internal medicine doc. Okay, internal medicine. And I think the internal medicine percentages should be about 45% level 4s. It was I don't know, it was 15% level 5s. It was 35% level 3s. Okay, that's the bell curve for them. I had one doctor, it was 95% level 5s. 95%. And I sat across from her, and she was the nicest lady, and she was a great doctor. I'm not criticizing her doctoring skills, and she was wonderful with her patients, and she had a heart for them and the whole deal, but what she was doing is she was billing inappropriately, and she got scrutiny. I mean, you know, that she's an outlier, like get out an outlier. There's no reason, if everybody across the country, if this is what CMS says, all internal medicine practices in 2010, by internal medicine standards, were this, then why are you at 95% level 5s? Who are you seeing? I mean, you're off the chart. She didn't understand this, you see? Okay, so you get on that benchmarking tool and you click whatever specialty you are. I mean, that's what I first do. If you're a cardiology practice, what are you supposed to be? Then I'm going to look at some of your charts and I'm going to find out where you guys are. And are you off the chart? And because if you are, you're gaining scrutiny. And if you're undercoding, what are you? You're losing money. You should be in that range, okay? Right? Okay, so general setup of a template. So this is just a general, so you got the chief complaint, you got your HPI, and see, when we go through the HPI, have you all done any of this? Okay, good, okay, good. Because, you know, like the context, the severity, the location, all that crud. Okay, very good. And then review of systems, that's the subjective part. That's a subjective part, you know, where you go back and forth. Do you have this, do you have this, do you have all. Now, I'll tell you right now, a doctor in practice right now told my daughter, oh, you need 14 review of systems for a comprehensive. It's 10. Even he doesn't even know, you see? So, because he's counting all of it. You have a lot, but you only need 10 plus for a comprehensive. He didn't know that, because she whipped out the tool and showed him, okay? Okay, and then past family social. Okay, here's your exam piece, objective hands-on. And I love this differential diagnosis. Some of the templates you'll see that, where this is the ER line, where they'll come in and they'll say, okay, it could be this or this or this. And then I know in the doctor's mind what he's thinking. Okay, he's thinking this is pretty serious, it could be this, this, or this. I like that. Especially if I'm on the fence between a level 4 or 5 or a level 3 to a 4. I want to know what's going on in his mind and what he has sort of had to rule out or rule in. All right, so I love that differential diagnosis thing. And then here's where he puts all of his information. And this is the medical decision making. What labs? What were the results? What x-rays? What were the results? Did he read the x-ray himself, or did he just read the, because that counts in medical decision making. Did he actually look at the x-ray himself? Did he actually look at the EKG himself, or did he read the report? Because you get credit for that, because that's risk. Because remember, what is the doctor paid on? He's paid on the risk. If he's actually looking at the x-ray and saying, that's a fracture, or no, that's not a fracture, you're taking the risk to say that, all right? Ultrasound, CT, EKG, procedures. Remember, I showed you the one where they had the procedure for the suturing. You know, you'll see templates where they're all set up. Consults. This is important in medical decision making. Did you ask for another consult from another doctor? If you did, that counts towards medical decision making, which is this side of the box, which is box C. We're gonna show all of that as we go through the notes. And then also clinical impression. Please give a clinical impression if you know one. If not, you got to revert to signs and symptoms. If they came in with ab pain and you've ruled everything out, it's ab pain. Go home with some, you know, drugs. Okay? And then signature and date. Always have to do that, or otherwise the note doesn't stand. Okay? 95 versus 97 guidelines. You'll hear talk of this. I'm going to teach you the 95 guidelines today. You can use whatever guidelines are most beneficial for you, okay? And basically, there are weaknesses and strengths of both, okay? And we're going to talk about both of them. 97 guidelines are good for like specialties, like if you're an orthopedic practice or if you do like one thing, okay? Whereas the 95 guidelines are good for like general practitioners because you're going to be looking at all the different systems. Because this has to do with the exam piece. The 95 and 97 guidelines have to do with the exam. All right? Are you going to do a full exam on one body area? Orthopedic, ear, nose, and throat, OBGYN? Or are you going to do a full body area, full body system like musculoskeletal, GI, GU, cardiovascular, respiratory? You see, therein lies the difference between 95 and 97. It seems like specialists do better with the 97 because it's a lot of bullet points on one different system. So basically, if you hit all of these bullets on this one system, that can count as a full exam, okay? And there is a downfall of the 95 guidelines, and I'm going to show that to you when we do the notes. You're going to see that, okay? All right. But the 95 guidelines are the best guidelines as far as generally, and to learn, it's the best to learn, okay? The single overriding factor controlling E&M leveling selection is the medical necessity. The volume of documentation should not be the primary influence of which the service is billed. I've said this over and over. Volume of documentation doesn't mean appropriateness of documentation. It still goes back to medical necessity, all right? And the three key components, the components of medical necessity right here, box A, B, and C, that's what we're talking with now. Number of possible diagnosis or management options, that's box A. Risk of significant complications, morbidity or mortality, that's box B. That's the table of risk. And amount and or complexity of medical records, diagnostic tests and or information that must be considered for review, that's box C. Now listen, as we go through these notes, you're going to say, gosh, you do this for every note. Basically, you get it in your head and you realize, you know, after you do them over and over and over again, you're like, okay, I got that. You know, but right now we're going to go real slow, and we're going to use the audit tool, okay, and the audit sheet. But like, I don't do that. I can do it in my head, looking at a note, because I do so many of them, and you will too, okay? But not right now. Okay, so here's your audit sheet, and this is what was given to you, right? This is the Novitas. This is from Novitas. This is our Mac carrier in Maryland. But this tool is on yours as well. Your Mac carrier is First Coast, FCSO, First Coast System, something or other. I don't know. It's based in St. Augustine, Florida. FCSO, I think it's called. But anyway, that's your Mac carrier, Medicare Mac carrier. They have a lot of good tools on there. They actually have an E&M leveling piece where you're going to do exactly what we do on their website, and you push calculate, and it'll tell you what the level should be. So you can actually, if you're as you're learning this, and if you're confused about whether this should be a level 4 or level 5, go on that website, put all the information in, and push calculate, and it'll tell you. Okay, as you guys get to learn it more and more. Okay, so this is the first part. Here's your history. Okay, so you got the HPI, the ROS, and the past family, and you put the information here. Okay? And then you've got the examination piece, and you've got body areas and organ systems. And we're going to do organ systems. All right? And then a problem focused is one body area, an expanded problem focused is up to 7, a detailed is up to 7, and a comprehensive is 8 or more systems. Now, do you see the problem? This is the problem of the 95 guidelines. You see how it says up to 7 and up to 7? Okay, here's how you differentiate between an expanded problem focused exam and a detailed exam. A detailed exam would be 4 systems, 4 things. So it wouldn't be like clear to auscultation, that's respiratory, right? No, it's clear to auscultation, something else, something else, something else. 4 things in the respiratory, 4 things in cardiovascular, 4 things in derm, you know, and then 4 things in something else. That gives you a detailed exam, 4 by 4. Think about that, 4 by 4. 4 systems, there you go. 4 organ systems, 4 things. That tells us detail. And think about that. That sounds detailed, doesn't it? 4 by 4. Just write 4 by 4, 4 by 4. All right, otherwise it's an expanded problem focused. If they just say clear to auscultation, regular rate rhythm, that's 2 right there, but it's just 2 different systems. Okay, that's not a detail. All right. All right, and here's the other, which is basically what I put this on the back of this, but it's also on the second page of your audit tool. Okay, it's box A, box B, box C, and you put everything down here. All right, so here's our audit tool. Here's our audit sheet. Okay, it's page 1 and page 2. We're going to do all of it for 3 different notes, and we're going to put the information in, and then you're going to use this thing to see what it says, okay? What it is, all right? You ready to do the first one? Okay, we're going to do 1 note, and we're going to take a break. Okay, so it's going to take us about 15 minutes to do this one, because we're going to go real slow, all right? Then we'll take a break, and then we'll do 2 more and finish. All right. Let's practice. Note number 1. Here's an ER note, okay? All right, so here we go. We've got an HPI. It's an injury to the right ankle. Onset and duration, 2.5 hours. It happened at home. The context, he twisted. The patient was walking in flip-flops and it got caught on the floor, subsequently twisting foot inward. So there's your context. Severity, unable to bear weight. Location, right ankle. Okay? Okay. So let's go back. Sugar. Let's go back. Okay, so HPI. Here's your tool. All right, what do you have? I have location. Hold on, I got the wrong one. There we go. I have location. I have duration. What was it, like 2.5 hours? Context. What is she, trip on her flip-flop? Okay. Associated signs and symptoms. I didn't see that. Hold on, but I have it written down, so let's look. I missed it. Unable to bear weight. There it is. Associated symptoms. Unable to bear weight. Okay? Okay, so how many HPI do we have?
4.
Okay, so basically what you do, you come over here and you check that box right there. Okay? Now, you see this thing up here? It says HPI status of 3 chronic conditions, or this HPI. You see how it says this or this? If you do 1 to 2 chronic conditions or status of 3 chronic conditions, I do the chronic conditions for like somebody that's an internal medicine guy, and the patient comes there every 6 months because they have hypertension, diabetes, and hyperlipidemia, and they got to check them and do the finger stick and make sure their labs are fine, and they prescribe meds. I do the status of 3 chronic conditions for that. Okay, that's for that. You can either do that or what we just did. Okay, yes.
Would you do like exacerbation of chronic disease, like patient's already diagnosed hypertensive, he has hypertensive crisis?
That's fine.
Go to the chronic opposed to?
As opposed to what? I'm sorry.
Because I thought we could either
Yes.
do an HPI or HPI of the chronic.
Yes, indeed. But you need 3 or 1 to 2 right
Oh,
there.
okay.
1 to
So
2.
it could go either.
Yeah, and any kind of, I don't, whether it's exacerbated or not exacerbated, if you just managed it, there you go, boom, you count 1. But that's good for that. If that's when I use the 3 chronic. If I'm, if it's a guy who sees the patient all the time. But this is I know. And by the way, I know this is an ER note, and I know we're doing an outpatient visit, but the ER notes are so easy to see everything. Do you understand? That's why I'm showing it to you. Okay, because I want you to see where everything is, and I want you to get the hang of using this tool. Okay, I know this is an ER note. Okay, I know that. Okay, but we're going to pretend it's an office note. Okay, all right. All right. Okay, now, the review of systems. Ankle swelling, right? Right? It looks like he didn't manage anything else. He just saying that. Okay, so we go back to our note. And review of systems, musculoskeletal, right? 1. Okay? Right? All right, past family, past history is hypertension. He's on hypertension medication, and he has a social history of occasional alcohol. Okay? So let's go back. Let's put that information in. I got a past history of hypertension, check that box, and a social history of alcohol use occasionally. Okay? I've got some coders who will code that as alcohol abuse. That's ridiculous. That's just ridiculous. I never do that. And that's another thing I never do. I never give people drug or alcohol diagnoses unless it's legit. I mean, somebody has a glass of wine with, come on, sheesh. But I've seen it. I've seen it. When I audit some records, sometimes I'll see it. I'm like, what in the world? If you're putting that on someone's record, see that's another one I don't do. I don't do any kind of psych diagnosis unless it's legit. I don't. Sheesh. Okay. All right. So here we go. So we've got 4 here. We've got 1 there, and we've got 2. Okay. But remember, you need all 3 of these. Okay? You need all 3 in a line, and we don't. What do we have? We have an expanded problem focus. See, because we had extended here, and we had a complete here, but we didn't have a complete review of systems. We had a problem pertinent review of systems. Remember the musculoskeletal ankle pain? Okay, so we need 3. So we don't have 3, we got to back down. We've got expanded problem focused. Do you understand that? Okay, so right here, I want you to put EPF history. Expanded problem focused history. Okay? Good. See, because right here it says this. It says, look up at top, it says, after referring to the data, circle the entry farthest to the right in the table, which best describes the HPI. If one column contains 3 circles, draw a line straight down that column to the bottom row to identify the type of history. If no column contains 3 circles, the column containing a circle farthest to the left identifies the history, which is what just happened to us. We had to back down. Okay? So it's right there for you. Okay? So, all right, here, whoops. All right, here we go. Here's the exam. All right. I have a lot of extremities, which is a lot of musculoskeletal. Do you see that? And this is all musculoskeletal. The leg. But I do see some swelling, so I would give lymph for that. Wouldn't you? Some lymphedema, you know, because he's talking about swelling. Okay? But a lot of it is musculoskeletal. I know this is done and see, I hate that when templates do that. They'll mix body areas and organ systems, and I hate that. You got to do one or the other. But I don't care if it says extremities up here, which is really a body area. It's still musculoskeletal. Okay, so this is all musculoskeletal. Would you agree with that? Except for the swelling. I would give that as lymph. Would you agree with that? Okay, good. Okay, so here we go. We got that too. Let's go to the second page. All right, I've got neuro. Okay, I've got some respiratory, cardiovascular, abdomen. Okay, which would be like GI. I would give that as a GI. Okay, gastro, you know, because they're doing abdominal stuff. All right. All right. I don't see anything 4x4. Would you agree with that? Do you see anything 4x4 here? No, I don't see anything 4x4. Let's go back to the exam piece. Here we go. Okay. What did we have? We had like respiratory, we had musculoskeletal, we had neuro, we had some lymph stuff. Do we have, here's the question, do we have 8 systems or more? No. No. Do we have a 4x4? Do we have a detail? No. No, what do we have? We have expanded problem focused. We have up to 7 systems that weren't done in detail. Because remember, details, any 4 things on each. And we didn't get 4x4. And we know we don't have 8. We know we don't have a complete exam. We already know that. So boom, right there, we don't even need to discuss this anymore. We have an expanded problem focused exam. So over here, underneath the history, put EPF exam. All right? That was an easy one. Okay, now let's do the medical decision making part. All right, which is the fun part. Okay, the other stuff is just bean counting in my part. Just bean counting in my mind. Okay, here we go. They splinted it. They did an X-ray. They discussed it with the radiologist. Do you see that right there? Do you see how it's not interpreted by me or reviewed by, or interpreted by me? He does not check that. He discusses it with the radiologist, though. That counts. We'll show you where. Okay, so he does an X-ray, discusses it with the radiologist, puts a splint on it, and he gives him an RX. Do you see that right here? RX given, Norco 7.5, 1 tablet PO, blah, 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 as pain. The plan, splint and crutches and pain meds. Follow up with the primary care physician. Not sending him an orthopod, sending him to the primary care. And basically that always happens in the ER. Just go to your primary care doctor. If it was really serious, you'd send him to an orthopod. Okay? So right there, that's another piece of information in my mind. Okay? Here's your diagnoses, and he signed it, although I whited that out. So here's your diagnoses, sending them home. Okay? So let's go back and let's put all this information in and let's see what we've got. Okay, here's this piece. Okay? All right. Would you say this is a new problem to the examiner? Yeah. Yes. Here it is. Read. This is box A. New problem to the examiner, no additional workup plan. No additional workup plan means I'm not sending you somewhere. I know we did an X-ray here. I'm saying that's not what that means. What that means is I'm going to send you to an orthopedic doctor. No. I want to send you for an outside MRI. No, that wasn't done. Yes?
So anytime you had someone actually presenting in the ER, you would use one of the new problems?
Yeah.
Okay.
And that's why they're always a new patient, and that's why you always need
Okay.
3 of 3. See, the burden of proof is more, even though they might be frequent flyers, but you really don't know this person from Adam. You know, you really don't, so you gotta like manage everything, okay? But now remember, this is an office visit now. I know. Okay, so here we go. This is a new problem to the examiner, no additional workup planned. He didn't send him anywhere else, except for the PCP, but that's just standard operating procedure. Okay, so now, let me go over this box real quick. If it's a self-limited or minor problem, stable, improved, or worsening. Self-limited or minor would be like a cold, an insect bite. It's minor. Okay? Anything that you're going to do that's going to get better with a little bit of treatment. Okay? Established problem to the examiner, stable or improved. Established problem to the examiner, worsening. That's why any kind of verbiage that you use exacerbation. You use the word severe. You use the words getting worse. Use those kind of words, okay? Because they all count in this risk thing, because it's showing how much risk you're taking, okay? All right, new problem to the examiner, additional workup planned. Okay, that's how you do box A. So this is what we do. We take however many diagnoses it is, and we put that information in this column B, and we do it times, that's multiplication, column C, here's your points, and it gives you your result. Okay? Simple math, all right? Okay, so new problem to the examiner, a maximum of 1. You can only do a maximum of 1 in this tool. Okay? And we had 1. We had an ankle pain. It's new problem to the examiner, so you put there 1 times 3 equals 3. Box A, the results are 3. So you come down here and you put 3. Box A, circle multiple right there, just circle it. All right? All right, okay, box B. This is the table of risk, and this is an awesome table. Look at this. These are presenting problems in order of hierarchy: minimal, low, moderate, high. This is the diagnostic and procedures ordered: minimal, low, moderate, high. They keep going up. And then this is the management selections option, selected: minimal, low, moderate, high. Now in this box, it's easy. All you need is 1 circle in the highest level, and you got it. You don't need 1 from every one. You don't. Just find the highest level: high, moderate, low, or minimal. I don't care what box it's from, and that's the level you've got for box B. And these are the things I look for. Okay, this is what I use an awful lot. Okay, ready? All right. 1 stable chronic illness, well-controlled hypertension or non-insulin dependent diabetes, BPH, that's low. Acute uncomplicated illness, cystitis, allergic rhinitis, simple sprain, that's low. Ah, we have a simple sprain, don't we? Circle that. Let's see if we can get anything better than that, but right now we've got that at least. We at least have low. Over here, right here, I love this one. 1 or more chronic illness with mild exacerbation, progression, or side effect of treatment. Now, I know it says mild. Well, what's mild? You guys decide what mild is. It's a gray area, mild, okay? But then look down here. 1 or more chronic illness with severe exacerbation, that's high. So that's why you need to use these words: mild, severe, exacerbate. Just use them, okay? All right. 2 or more stable chronic illnesses, that's moderate. Undiagnosed new problem with uncertain prognosis, a lump in the breast, moderate. Acute complicated head injury with brief loss of consciousness, moderate. And then here, high. This is high. Acute or chronic illness that may pose a threat to life or bodily function, an abrupt change in neurological status, that's high. Okay? So chest pain, delirium, confusion, those things are high. Now remember the internal medicine doctor who's doing 95% level 5s? You mean to tell me that these people are coming in with that kind of stuff? 95% of the patients you see? And you're just managing their hypertension, diabetes, and hyperlipidemia. She was an internal med? See, you see, it doesn't wash. It doesn't wash. It shouldn't be high. Okay? All right. So that's the presenting problems. These are some things. We already got low on that. Let's see if we can get anything higher than low. If we do, fine. If not, then it's going to be low. Here's your diagnostic tests ordered. So you got a chest X-ray, urinalysis, okay? Physiological tests under stress, cardiac stress test, that's moderate, okay? And then I love this. I love this management option selected. So basically, if it's over-the-counter drugs, you're at low. If it's prescription drug management, do you see this here? That's moderate. Okay? And parental controlled substances, you're at high. All right? So those are some of the things I look for that I see a lot of, and then that helps me grab. Okay, so basically they did a splint. So basically, they didn't even send them for PT or anything like that. So that's here, that's minimal. I can't get anything higher than low, really. Can we find anything higher than low for this patient? I don't. Oh, that's right, you did, very good. Prescription drug management, we got moderate, easy. As soon as they get prescription drug management, that's a game changer right there, it's moderate. Okay, so there we go. Okay, so come back down here and put moderate. So we got 2, 1, 2. All right? Now, in this box, all you need is 2 of 3 circles. Do you see that? It says right here, draw a line down any column with 2 of 3 circles to identify. So basically, right now, what is our medical decision making? It's going to be moderate. But for the sake of teaching you, I'm going to show you how to do this box right here. But right now, I want you to go back to this page, and I want you to put moderate NPM. Okay? So we now have our history exam and moderate medical decision making. We're gonna see what level that is in a second, but I want to show you how to do this box right here. Okay, this is box C. Amount and or complexity of data. Okay, so basically, it doesn't matter how many review and or order of clinical lab tests is 1 point. If you order a lab test, it's 1 point. If you order 5 lab tests, it's 1 point. It doesn't matter, just a lab test. It doesn't matter how many, you don't get credit for extras, it's just 1. So you circle 1 for that. But they didn't do any labs on this guy, did they? Okay, so review and order tests in the radiology section. Did they do an x-ray? Yes, circle that, that's 1 point. Okay? Review and or order tests in the medicine section. The medicine section is the 90,000 range section in the CPT book. That's EKGs, okay? Stuff like that. So as soon as they do an EKG, I'm right all over that. So if they do labs, x-ray, EKG, I've got 3 points, that box, boom. I already have moderate, easy, okay? All right, discussion of test results with the performing physician. Did he do that? Yes. He discussed it with a radiologist. Circle it, that's 1 point. Decision to obtain old records and or obtain history from someone other than the patient. You'll see that mentioned in the notes. I had to pull the old records and I reviewed them. Boom. You decided in your clinical judgment you needed more information, so you pulled the other notes. You're taking time to do that. You should get paid for that. That all counts in the amount and or complexity of the data you're looking at. Okay? And review and summarization of old records. See, that will be the difference. Whether you just looked at them or you summarized them. Hence the difference between 2 points to 1 point. Okay? And then independent visualization of image. Remember that one box in the note where it said, I looked at the x-ray myself? That would be right here, 2 points. Or if you looked at the EKG yourself, and that would not just read what the cardiologist said. You actually looked at it. See, that's worth 2 points. But in this box, how many points did we get? 2 points. So down here to 2, it's low, but we still have 2 in the moderate section, so we're at moderate. Okay? Okay, so here we go. Let's go back. Let's go back. Here we go. All right. Now these are the codes we want right here. We want a new patient. We need 3 of 3, and this is what we have. We have expanded problem-focused history. We have an expanded problem-focused exam, and we have moderate medical decision-making. What do we have? 99202, because we need 3 of 3, yes.
I'm sorry, I thought in the amount of complexity data, I have 3.
Now complexity, okay, what'd you get?
I got the radiology.
Yep.
Study order.
Mhm.
You discussed that with another physician, which is the
Mhm.
radiology. And then you discussed obtain the records.
Did he do that? Did he obtain the records from somewhere?
I thought you said
No, I didn't see that.
that. Okay.
Yeah, that would be if he would.
All right.
I didn't see that in this note. Yeah.
Thank you.
No, that's all right, that's all right. Okay, so here we go, we got a 99202. Okay, now let's say for the sake of argument, this is an established patient coming into you with this. He's your regular patient that you see for something else, okay? Now what do we have? We have an expanded problem-focused history, we have an expanded problem-focused exam, and we have a moderate medical decision-making. What do we have?
99213. 213.
We have a 9, we need 2 of 3.
2 of 3.
213.
213.
We have a 213. I know we have moderate medical decision making, and I know that's the overarching criteria, but do we have anything detailed in here? So we can't.
No.
We gotta back it down. You understand?
Mm-hmm.
And now, I would never do this. I would never have a moderate and then have comprehensive and bump it up. But we just bumped it down on that account. Do you understand there's a difference there? We at least have the moderate medical decision making, and we had to bump it down because we don't have enough exam. Or we don't have enough review of systems. It was the review of systems that did it. If you go back truly, it truly was the review of systems. However, does this feel like a level 3 to you? It's a sprained ankle. I mean, it should be a 5. Should it? Who's the lady that was in the ER? They were clicking things and everything was a 5. Should this be a 5? No, it should be a 3. Okay, now think. Okay, level 1, it's like, that's a joke. They shouldn't even be here. I mean, come on, put a Band-Aid on and stay home. Okay, but level 2 should be like a rash and no meds given. I mean, come on, think about it. Level 3 could be an ankle sprain because they're pushing meds. That's what did it. Okay, they gave him a med. And then level 4, I'm thinking abdominal pain, and that could be a 5 for heaven's sakes. And then level 5s are like chest pain, change in mental, change in neurological status, like, whatever.
So had this patient, or had the physician then either better documented or better performed in an exam, they could have bumped it up from a 2 to a 3?
Yes. Yes, and they could have gone, and at that point they would have gone to a 4 because it would have been a detailed exam. But I think to myself,
Is it really a 4?
they were in flip-flops. I mean, this is not an 80-year-old woman. I mean, she's in flip-flops. It's obviously a young person. You know what I mean? It doesn't feel like a 3 to you. Yes. And it makes sense. And you're not pushing something, and then you're not feeling like, oh man, that wasn't right. Yes.
What about the time it took to splint? Because that takes time.
You get paid for the splint. Yes, you get paid for the splint. Yes, you do your E&M level. That's awesome. You get paid for the E&M level, the 99213. Put a 25 modifier on it so that you get paid for the splint. The splint gets on there, so you get paid for the splint. Yeah. So yeah.
That doesn't modify this at all.
No, but you get paid for it because it is taken into account in the medical decision making, that table of risk. Okay, but you get paid for the splint. Now, I'll take a question. Just 1 second. The 25 modifier on the E&M level says that you did something else besides just the E&M level, and it'll get that splint paid. Otherwise, the splint will get paid and the E&M level won't. The 25 modifier on the E&M level says there's a separate identifiable E&M level on top of the procedure, which was the splint application. Okay? And so they did the splint and then the E&M level. Put the 25 modifier on the E&M level and you get paid for both.
Okay.
Yep. And put, what was it? Was it a right leg? You put an RT on the splint. I think it was right leg. It might have been left. I don't even know. Yes?
Okay, I got confused after we did box C.
Mm-hmm.
Okay, so I get how we checked 3 different boxes and it was a total of 4, so are you counting the number of boxes? Is that how you got multiple moderate? Like, I didn't understand how you got to moderate from box C.
Box C?
Yeah.
Oh, box C was low. It didn't, all we need is two or 3 boxes. Here, let's go back. I'll give you your full 10 minutes, don't worry. Here we go. Ready? It's really important you get it. Okay, so box A was 3. Did you get that?
Yeah, I got A and.
And B.
Box, yeah.
And B. Okay, so we only need 2 of 3 boxes in this. And see, it says it right here. Any column with 2 or 3 circles, 2 or 3 circles. So we got moderate because it goes straight down to moderate.
Okay.
Okay? And we just did box C only because I wanted to show you how to do it. It didn't.
What would have it been?
Huh?
What's it?
What was box C?
Box C was 2. Up here.
How'd you get, oh, because 2 is the largest number?
No, 2 was, we did something in the radiology section, that was circle that, that's 1. And we discussed it with the radiologist, that was 1. And we totaled that as 2.
Okay,
And then we put that down there, but it didn't matter because we already had moderate anyway.
okay.
Yeah. Okay. Not that hard, you know, not that hard. You get the gist of it. Okay, we got 2 more notes coming. And then we end up. Okay, so hey, hold on. Okay, 10 minutes from now, I'll give you a little extra time. All right.